Hello there, and welcome to the 2022 Digital Health Virtual Series. My name is Matt Rayner. I'm the publisher here at Healthcare Innovation, and we are so excited to officially start year 2 of the Digital Health Virtual Series, and we get to kick things off with a day devoted completely to the topic of interoperability. Today's Interoperability Virtual Day is going to feature sessions diving deep into the topic of interoperability. And we want to thank you all for being a part of this program. Whether you're watching this content live here with us today on January the 26th, or you're consuming this content on demand, a big thank you to you. Today's event, of course, would not be possible without the support of our partners at LexisNexis Risk Solutions, Infor, and Spoke. So a huge thank you to each of them. A quick note on our partners at Spoke. We have a resources library within the Interoperability Virtual Day portal with some great content that I encourage you all to check out. The sessions today are designed to be interactive. So if you are watching with us live at any point during the sessions, you are welcome and encouraged to submit questions by utilizing the chat functionality within that Zoom console. Okay, with that said, I would love to officially kick off our Interoperability Virtual Day by welcoming on our editor-in-chief here at Healthcare Innovation, Mark Hagelin, to introduce our opening session, Policy, HIE, and the Near-Term Future of Interoperability. Mark, are you with us?
Yes, I am. Thank you so much, Matt. And good morning for all of those who are watching us live right now, and good day to those in the future. I always love welcoming those in the future. It feels very Star Trekky. But welcome to this session. I am thrilled to have a panel of true national experts with me. And before we go any further, I'm going to have each person introduce her or himself. And then we'll talk about this very fascinating, complex topic. So I'm just going to go around my virtual circle here. We've got David Horrocks, Angie Bass, Melissa Cotres, and Jonathan Shannon. Thank you all and welcome. So why don't we go in that order? David, go ahead, please introduce yourself to the audience. Thank you.
Thanks, Mark. My name is David Horrocks. I am the CEO of CRISP. We are the state of Maryland's designated HIE, and we operate as part of an affiliation of 4 other statewide HIEs.
And CRISP stands for?
Chesapeake Regional Information System for Our Patients. It's very hard to fit on your name tag at a conference.
But you've got a great acronym, CRISP. I love it. So it would be really bad if it were soggy. So I'm really glad for CRISP. Anyway, Angie Bass, welcome.
Thank you. Good morning, Angie Bass, Executive Vice President of Bellator HIE Corporation. It's a network, a national network for HIEs across the country for a national HIE network services and professional services and technical services.
Welcome, Angie. Melissa, welcome.
Good morning. My name is Melissa Cotres. I'm the CEO of Contexture, which is a regional nonprofit organization that serves as the umbrella organization for both Health Current, which is the statewide health information exchange in Arizona, as well as Correo, the largest HIE in Colorado. I'm also pleased to represent Civitas Networks for Health as the board chair, which is the National Association of Health Information Exchanges and Regional Health Improvement Collaboratives.
Welcome, Melissa. Thank you. And Jonathan, welcome.
Hey, thanks, Matt. Oh, Mark. I'm Jonathan Shannon. I lead up the strategy for our interoperability solutions here at LexisNexis Risk Solutions. Our company is a data aggregator and facilitator of data exchange to assist our customers in the healthcare space with managing risk and gaining insights on patients and the provider networks.
Thank you. Welcome all. We're thrilled to have you. We're going to dive deep here and we're going to talk about policy and operations. I'm going to start with, my gosh, if we didn't have enough acronyms in healthcare before, we certainly do now. So I'm going to start with TEFCA and USCDI. On January 18th, ONC, another acronym, the Office of the National Coordinator for Health IT, published the details of the Trusted Exchange Framework and Common Agreement. And then a day later, released the draft of version 3 of the United States Core Data for Interoperability, Core Data Set for Interoperability, USCDI, a standardized set of health data classes and data elements for nationwide interoperable health information exchange. So let's start. I would love to get the panel's just 40,000 foot up gloss on what these developments meant. Starting with TEFCA, you've had a chance now to look at the details of what was released. What, on a practical level, does the release of TEFCA mean? And then we'll talk for a moment about version 3 USCDI. Who would like to begin with TEFCA?
I'm happy to start, or David can.
Go ahead, Angie.
Well, we've been waiting to go, and so this is the go marker. At least now, not much of the TEF changed, so there wasn't a lot of changes there, and the common agreement as well. So I think, of course, certainly the standard operating procedures were released and working through those still, which is a necessary piece of it. I think some of the pieces that are still to be worked out are the use cases and the permitted uses. So leaving out some of the traditional use cases like benefits determination, see how that is going to develop. I think also some of the things that we are yet to be determined, that will be determined as QHINs are established and as connectivity is some of the local governance and how the TEFCA agreement is either more or less than state or federal law, and where there are incongruencies there, and how does that actually play out from a governance perspective. I think some of the fire standards are also, how yet will that be played out, and who will actually be able to do that and conform, and what will those conformance standards be. So I think it's okay that we don't have all of those answers yet, because we've been sort of gearing up for this for several years now. And so I think the beauty of where we are in this milestone is we're ready to go. We're ready for QHINs to start applying. We're ready for QHINs to be established by the recognized coordinating entity, which is Sequoia, and that there's some relief in the industry that, okay, now we can just step on the gas and go. But there's still some things to be determined. And then I think, just before I turn over to the rest of the group, is who are the QHINs that are going to be established, and who will be in the first group and who will be in the second group. I think that that is going to sort of signal where Sequoia, where ONC wants it to go, is who in the selection process. I think that I think they're already being thoughtful about who should be and who is. And so I think that once those entities are established of who are going to be qualified health information networks, that should signal a lot to the interoperability community at large.
Yeah, exactly, Angie. And I've been wondering exactly myself, which organizations will apply to be QHINs, which will be accepted. Who else would like to comment?
I'll agree with that last point that Angie made. Figuring out who the QHINs will be is, I think, the hard part. And we're on this path that I think is we're slowly getting to ubiquitous availability of clinical documents, when particularly in narrow use cases. You're at the point of care and you want the documents from someone else's prior treatment. It's getting easier and easier. The needs for an intermediary, they can be more lightweight. All those things are good. But whether it's the EHR vendors who are facilitating the bulk of that, or whether it's other organizations such as HIEs, it's really tough to say how it will develop.
Yeah. Jonathan and Melissa?
I would just add that I think I agree with what Angie and David mentioned. You know, it's a lot to digest, but the industry's been waiting a while for these details to be solidified. And so I think, you know, ONC and Sequoia went through a thoughtful process, incorporated, you know, a lot of different perspectives, or tried to incorporate as many perspectives as possible in the process. And it'll be really important to continue to track progress. I think as health information exchanges, this is our business. The interoperability is what we do day in and day out. So we have obviously been tracking it carefully. And now that some of the final documents have been released, we'll be looking deeper at strategic opportunities, how this impacts our business, and then to the points that were already made, who applies for and who is approved or selected as a QHIN, you know, could or couldn't change the landscape from what we have today. So I think it'll be important to track it going forward. And certainly it's something we keep a close pulse on, just because of the impact to our organizations.
Exactly. Jonathan?
Yeah, no, I would agree with all the other panelists. You know, I think the rulemaking has indicated directly there in the name, right? Like this is the first step. This is the go markers Angie indicated, right? It's V1 of the TEFCA, the Common Agreement and Trusted Framework, Exchange Framework. So, and then also in there is the need, the desire to have a FHIR roadmap, right? They know that this is not the end, right? So this is not the way that we're going to exchange data forever, but this is the start. And so I think right here we have an opportunity to see how this very thoughtful, as Melissa indicated, a lot of moving parts, a lot of input into how this data should be exchanged, how that starts to work, and then we iterate from there. And it's going to be interesting to see who is successful in this, and you know who's able to gain scale and be able to facilitate meaningful data exchange.
Okay, let me ask all panelists two questions that are a little interrelated. Are you overall pleased with how this iteration of TEFCA turned out? And were you surprised? Were there any surprises of any kind? So whoever would like to opine.
I don't know if I felt like there were any surprises. I think that leaving out some of the use cases that are pretty typical and standard, especially in the HIE community, is just sort of like, okay, and seems sort of like a lost opportunity, but I'm sure that there are reasons for it. And I just don't know if they've done a good enough job to describe those reasons. But I also—
Were there a couple of use cases that you think should have been in there, Angie?
Yeah, I think the eligibility determination is a good one, and some operational and items. I think that's sort of core business to HIE. So, but I also think that we're in a game, not a game, but in a process of phases, and success breeds success. And so if we can get TEFCA up and running and QHINs are established and we can prove the model, and then we can add and we can add and we add as we learn the lessons, then that's a thoughtful approach too. And I would support that. I think sort of doing everything at the beginning is complex. I mean, this work is not easy, and no one outside of it should walk away with that or ever have that impression. And so I think being thoughtful about adding use cases one step by step is okay. I think that just making sure that HIEs in particular are well represented and validated through this process is incredibly important.
Everyone else, I'm sure you have thoughts.
Yeah, I don't know that there were any surprises, as Angie mentioned. To be honest, our team is still digging into the details to see what it means to us as an organization. I know as a national association through Civitas, there has been some concerns about what the role of HIEs can or could be in the TEFCA framework, and that has evolved over time. And so I think that will be important to tease out, and whether HIEs are looked at as potential QHINs and or, you know, generally excluded as potential QHINs is certainly an important differentiator for organizations like us, because we see ourselves as critical components in the interoperability framework. There's lots of different layers of interoperability, and HIEs play a really key and critical role. So I think what we need to understand, even to some of the answers to the last question, is as QHINs are applying and selected, will indicate whether or not, how HIEs play in the whole framework, and any disintermediation of HIEs certainly would be a disappointment to our organizations and our colleagues. But I don't think we should make that foregone conclusion until we have time to dig in deeper and see how some of the QHIN selection process plays out over time.
In other words, the proof will be in the pudding.
Exactly.
David and Jonathan, were there any surprises for either of you, or did you, and overall, is it what you were hoping for?
I think it's what we expected. There are it was 77 pages of material between the two documents, I think. So there are a few particulars. One is that the QHINs are supposed to exclusively work through the common agreement in their, or through the whole TEFCA framework in their exchange with each other. So these organizations probably who will apply have existing exchange happening. How will that work? That was a question that we had, but I imagine it'll be figured out.
Yeah, exactly. Jonathan.
I would agree. I mean, there was nothing that was particularly surprising. I mean, I would let my esteemed colleagues here speak to it more, because this kind of data exchange applies more to their business than to ours. But I mean, for me, I was not that surprised by anything that we saw as it relates to TEFCA. The thing that I was quite happy to see is this idea that moving towards FHIRE, that roadmap that I alluded to earlier. I think that is going to be a fundamental game changer for how data exchange happens. You've already seen some of that, the patient access APIs. They're being published by health plans, and then will be published by EMR vendors in 2023. I think that's going to help facilitate and standardize data exchange across the healthcare industry. How we get there, that's another big question, but I think acknowledging that that's something that needs to happen is going to be key.
Yeah, exactly. I agree. Does anyone, I mean, I know the draft of version 3 of USCDI is not exactly, first of all, it's not the sexiest thing in the world to talk about, but does anyone have any thoughts? Were there any surprises there? Just any thoughts overall on the release of that draft of version 3?
Haven't looked really close at the particulars of that. It's certainly a good thing to have these standards propagated, whether it's USCDI or FHIRE, as Jonathan said. I mean, in my experience, just having a standard, though, is not enough. Implementing the standards, having use cases between parties or via an intermediary, it's just a lot harder. It's just having the standard does not usually create tremendous progress all by itself.
Yeah, I just want to echo that point. I mean, I think it's great that the continued annual refresh of USCDI. I think it's every January they're trying to release something new, create a more holistic view of a patient or a member. I think this latest version was more around the coverage and things like that versus the version 2, which started to integrate elements of socioeconomic determinants of health and how that impacts care and things like that. But I have to completely agree with David. I mean, as far as I know, the version 3, I mean, I know version 3 is not mandated because it's still in draft form, but the version, as long as there's no enforcement about this is how the standards have to be used, this is what it needs to be used for, these kind of things, I think it loses a little bit of its teeth. That being said, it does lay a good, I mean, as we've discussed with TEFCA as well, it lays a good framework for people to start operating off of and start realizing how it works, and I think it's a good situation.
Good.
Yeah, I would.
Oh, please go ahead. Please go ahead.
I definitely want to ping on what Jonathan is saying. Is standards without enforcement are just that. They're just standards that some will aspire to and some will not. And so without enforcement, and there's not going to be uniformity or conformity across the industry, which is what we need. And what that means is at the end of the day, some providers are always going to be left out because the financial weight that it takes to have interoperability, they are not going to be able to afford. And all that does is snowball down the whole interoperability chain, leaving providers out, leaving patients out, and not having their data accessible everywhere, which is the ultimate goal. And so USCDI is great. I wish that it had more enforcement, and with that is penalties, and that it is tied into reimbursement, and it is tied into ways for providers who have these EHR systems and have HIEs for them to be able to cost recover for that. The financial side of it is very important, as well as the policy side with the USCDI. So totally supported. I think there are just some really key pieces missing.
I really appreciate all of your insights on that, because that goes far beyond my familiarity with the context of USCDI. So thank you. So let's shift a little bit here and talk about something that's been affecting every person on the planet, which is the COVID-19 pandemic, but in the context, of course, of health information exchange. Panelists, how do you feel? One of the things that has been said, no one wanted, a viral pandemic to hit the earth like a meteor. But one of the things that's been said is there has been a strange silver lining around health data exchange. And that is that it has made people, the pandemic has made the light bulb go on over the heads of many people in the US healthcare system, realizing, oh, we need to share data. And one of the very specific things that's happened is the awareness of the fact that our public health information sharing system is broken, fragmented, not complete, whatever you want to call it, it's not there. Now, the really good news is some of your organizations have really helped stepped into the breach. I know, David, I interviewed you about CRISP and how you just immediately, because you already had the relationship with the Department of Health in Maryland, right, you were able to step in. Everyone, tell me a little bit about that. How has, and I think I'll start with you, David, so you can just briefly mention what you've been doing with the state of Maryland, but how has the pandemic helped to shape the current moment for health information and data exchange? David, you go first, and then I'd
Sure.
like to everyone.
Mark, if you were an infectious disease doctor or you trained as a virologist, you've been busy the last 2 years, but it's also probably been rewarding. You've gotten to do what you prepared for. And that's how I feel as an HIE guy, is that we've been able to do the things that we were built to do. And it's been very, very busy.
Yeah.
But with the Department of Health, I think we've in particular done a lot more work with data sets, not just information that's moving for one patient from one place to another place, but taking something like the immunization registry and combining it with another data set like chronic condition flags out of claims, and being able to say, well, we know how we're doing with immunizations, but how are we doing with immunizations for groups that have particular risk factors, or doing the same with a COVID case file. We're working now to figure out how do we do this with the new therapies that are coming out, like the oral antivirals. So we are able to do things that the department can't do by itself, because it doesn't necessarily receive all this clinical information, certainly not identified. So we can combine data sets in ways that that other entities don't have, that trust relationships that have already been set up, and the oversight and patient protections that would allow us to hold that data. So it's been great to play that unique role among others in support of the department and their response.
Wonderful. Who else would like to comment on that?
Sure, this
Just
is
to
one that we
piggyback on David.
all have feedback on. Do you want to go, Jonathan?
Go ahead, Jonathan. and then-
No, I just a quick point to piggyback on what David said. I think another key item that came out of this is not just the facilitation of data exchange, but this idea of identity resolution, right? Today, you have so many more people interacting with the healthcare system than you ever did before, right? Whether it be getting their vaccines, getting their COVID tests, making sure that that person is the same person. There's Jonathan Shannons all over the United States. Am I the same person that I get the COVID swab and I get my vaccine and I get these treatments and I'm hospitalized for X, Y, Z? Making sure that data cannot be underestimated as the heavy lift of what is needed to happen on the back end in a fragmented healthcare ecosystem. And so I think absolutely there's a lot of, it's pointed to a lot of the cracks that were there, and it's forced some innovation to help resolve that. So sorry, Melissa, I didn't mean to cut you off.
No,
no.
I agree. And I'll just say there may be other Jonathan Shannons, but you're our Jonathan Shannon. So.
Oh, thanks.
Melissa, please go ahead.
I think this is a topic we could probably talk about for a long time. So I'll just allude to a couple examples. I think, for health information exchanges that had worked for years and in many cases over a decade to get connectivity in place and have data flow in a matter of days, we're able to, at the beginning of the pandemic, use functionality that was already there and data that was already flowing to help address critical needs. We were able to provide COVID-19 lab alerts to the community, to providers in a matter of less than a week. And we just had hundreds of providers that wanted access to that information. Certainly earlier on, we're in a different phase of the pandemic now because they had no access to that type of data because, the public health interoperability system is not really set up to distribute data back out to providers.
Right.
So we've been able to collaborate and be that intermediary between the healthcare system and public health. We now receive all COVID immunizations. The Department of Public Health now wants to send us all of their lab data in addition to the approximately 70% we already had. And we've done other things like support real-time bed capacity for the Department of Health Services, where the Department of Health was going to go to each hospital and say, can we get an ADT interface? And the hospital said, wait a second, we already send all of this data in real time to the HIE. And in a very short period of time, we worked with the hospitals, we worked with the Department of Health to code and make sure we were translating bed data appropriately. And it has been hugely beneficial even today in surges that we see within the environment that the Department of Health has real-time access, whereas they would probably be relying on manually reported information. I do agree with the identity management piece. Our colleagues in Colorado have worked with the ONC and over 20 HIEs across the country and have a lot of depth of knowledge and dashboards and analytics, and have been able to bring COVID lab data, immunization data into dashboards that represent multiple states of data to show what's possible, even across state lines and across HIEs with the power of interoperability we already had in place. So it was very rewarding to be able to demonstrate and be able to further validate the value that HIEs play both in their community and at the nationwide level.
Very well said, Melissa. Thank you. Angie, since everyone else has spoken on that, would you just like to share a thought?
Yeah, I mean, so in our world, I think it's been said a couple of times, this was our 9/11 in health data interoperability in public health. And it was our moment to shine as HIEs to say what we could do. And it's been amazing to be able to talk about that and finally have a validation, right? And at the same time, it showed a very glaring light on what has sometimes been a criticism of the HIE community of not all HIEs are cut from the same cloth. Well, the reality is that is true, but not for the reasons that most industry folks that are critics of HIEs think it is. The HIE leadership across the country is very strong. Like we are a very intelligent, thoughtful, innovative group. And this is a very specific niche. And every HIE in the country could be a CRISP, could be a Contexture, could be all of the notable HIEs that you hear about a lot, if they're properly funded and integrated into their public health systems like those are. Where states have not been active in leadership and incorporating from a policy perspective, or even involved or even believers in interoperability, then those HIEs have been left behind because they haven't had the financial wherewithal to do great things. And so part of what we'd love for to let this moment teach us is that part of the public health infrastructure is data infrastructure, and that HIEs are a critical piece in that, and that they should be supported as such, because we don't need pockets of success. We need national success, and all of the success should be tied together, because we have this great HIE interoperability community that works well together inherently, and that we should be taking advantage of it.
Yeah, I absolutely agree, Angie. And I also think we've almost gotten to the point where at some point the mainstream media will start writing about health information exchange. They're not quite there yet, but I've seen reports in the mainstream media where reporters have said, "Oh, if only we could make sure that data was being shared." And it's like, well, hello, it's actually, you guys know. I mean, and I'm a journalist, but I'm a trade journalist, but it's fascinating to me that the mainstream media still haven't discovered what HIE is. I guess this is too technical for them, or too specialized, or something like that, or they're too lazy. But I think it will be great when we reach the point at which what you guys are doing, which is so incredibly important, is actually begins to be appreciated by the general public. That the public will actually say, "Oh, wow, we really value the fact that key appropriate data is being shared appropriately, so that clinicians, patient care organizations can help us." I mean, I think that will be a wonderful day, and we're getting a little closer. So, well, let's talk about multi-state HIEs, all of whom of you who are on this panel who are running HIEs are running multi-state HIEs. One of the things that I've observed, again, just as a journalist reporting on this for years, is we've really gotten to the point now, as we know, initially there was a lot of federal and some state funding for the development of HIEs, and over time that ran out, and a lot of HIEs died. And some died because of a lack of funding. Some also died because of a lack of governance or clear sense of mission. Those that have survived, and you guys are among the survivors, are strong because you're doing things that people want. And you've got good governance, and you've got strong management, and you're providing, and you figured out a good business models. Tell me and tell our audience what lessons have been learned, and why multi-state HIEs are over time beginning to become the norm, and where that train is headed. Who would like to begin?
I think you're going to see more of it, Mark. That will continue inevitably. The economics are just too compelling for that not to happen. But it's not the only reason that I think it will happen. There are four, I think, notable multi-state HIE affiliations, three of whom are on the call. And they're each taking a little bit different tact, which I think is probably healthy to see how different approaches work. But the economics are very favorable, especially for a small state, to be sharing infrastructure. Just the cost of privacy and security alone can be a really big chunk of a small organization's budget. You can't go light on those things if you're holding sensitive health information. But beyond the economics, you have the ability to share innovations and share best practices, really, and to pool talent. And we're finding as we do that, an affiliation allows each state to say, well, what's working well in the other, and to pull in the subject matter experts when maybe they get the call with their epidemiologists in the state and they want to describe what's possible, and to gravitate around some common game plans. So I think you'll see more of this, Mark.
Yeah. Who else would like to add?
I would say I agree with everything David said. I think certainly it is a trend that's occurring for a number of reasons. All the ones that David mentioned, even between Arizona and Colorado, when Health Current first started having conversations with CoRio a couple years ago, really there was acknowledgement of we had strategic alignment in our vision, in our mission, in the direction we wanted to head, but were also things that we did differently. I already mentioned some of the expertise that the Colorado team has with analytics and dashboards and in-house expertise that we haven't historically had in Colorado. But we've got projects now that are ongoing with stakeholders in Arizona that's using expertise from our Colorado team members really to advance something that's important to Arizona. You know, there's examples where we have had more integrated physical and behavioral health information exchange historically in Arizona. It's something that stakeholders in Colorado were talking about for a number of years, and the discussion continues to heat up and the interest continues to heat up. So how can we bring that expertise, which is a very complex regulatory and compliance environment, not to mention technical environment, to enforce the compliance requirements, you know, to our colleagues in our other states. So those are just a couple examples that reiterate some of the points that David made. I think that what I've seen is over time, my time in this space is there are some key ingredients to success in the HIE space. Angie alluded to some of them in an earlier response, and really it's about how can we work together with our colleagues in other states so that we can identify the value of the services we provide, all the different use cases, which goes well beyond treatment and care coordination, and really be able to share those best practices and try out the different models. Like David said, there are different models in governance, different models in affiliation, and how you really structure things to gain those economies of scale and be able to scale up and do more and provide and grow and provide more value to your community.
Absolutely. Angie and Jonathan, would you like to share?
Certainly. I think it's the economics of it, as David said, is really the biggest driver. When you think about if you had to describe what we do to the layperson on the street, it's, everybody's got their 60-second elevator speech, but in the everyday, technical is just a very small piece of it. Managing the governance, both at a micro, local level, at a state level, and also at a federal level, that is 5 full-time jobs, right? And then you've got the community engagement piece, you've got the EHR vendor management. I mean, all the technical and operational pieces and the governance pieces of managing the HIE are really too complex for organizations that have less than 20 staff across the country, because you just need more in order to support the infrastructure. And I think that now, a decade plus into this, we just know better, and we know how we can get economies of scale and efficiencies on the technical side to be able to have a technology stack that can support, larger regions of the country. And that's very efficient. It's also very attractive to folks that want to engage with HIEs. If there are fewer to connect with, as opposed to having 80 plus, then that is an efficiency standpoint, and attractive to folks that want to engage with the industry and create more value for even downstream participants. And so it's just sort of been a long time coming. I think this is what we've needed. I think the ending of high tech really sort of put a stamp on where the industry needs to go. And it's just creating opportunities for the best fit for HIEs to align and partner and collaborate. And I think it's healthy for our industry right now.
Yeah, that makes sense. Absolutely. Jonathan, observing all of this development, what do you see?
Yeah, absolutely. And obviously LexisNexis risk is not a HIE, but I agree with everything the other panelists have said. From an internal scale perspective, I think that all makes sense. Taking a slightly different look at it, I think Angie alluded to this a little bit, which is the bigger the scale, the more attractive it is to work with you, not only as a consumer of the information, but as a as a patient and individual, right, as well, right? If you can get we all know healthcare is local. You're more likely to go to a doctor that's down the street but your location is not always static, right? And so if you have more scale, more data integrations, more points of where you can pull that data from, you can create a more longitudinal patient view. It becomes more and more attractive to do business with you and to do, we all know, and Mark, you talked about this a little bit around how consumers don't seem to understand their data is being exchanged at this point. I mean, we saw Google Health and Microsoft Health Vault and things like that, these PHRs come and go. And I mean, they were backed by companies with billions of dollars on their balance sheet, and and very smart people at them. It's something where I think if you are not facilitating a data exchange in a meaningful, scalable way, right, where different data is being pulled from different areas, different formats, it's not usable, it's not fungible, it's not consumable, you're going to really have a huge problem making it an attractive business proposition to anyone. And so, and it's not meaningful for outcomes of health. Your health, right? You're not going to avoid any acute events if someone can't read the data that's coming through. You're not, and if there's holes, it looks like Swiss cheese. So, I think absolutely this is a trend you're going to see keep going forward. Where the more scale, the more standardization you have, the better off you're going to be for both the consumers of your data and the patients themselves.
Yeah.
Hey, Mark. What I really hope to see as a result of this is that regions we sometimes call HIE white spaces that haven't been very successful yet. If these organizations can help those regions, finally figure out how to get it right, applying best practices and sort of proven approaches, that would be exciting to see, so that we get 50 states that are well served.
Yeah.
And to that note, I mean, it's hard to make the business work in those white spaces, right? Where but if you can fold it into a broader infrastructure and help support it through, other lines of business and things like that, absolutely, you can definitely do that.
Absolutely. Angie, I wanted to give you the opportunity to address one thing. When we had our call to prepare this session, you had made the statement that HIEs are still waiting to be officially designated in some states and in federal law. And you had said we need to be designated and certified on the national level. Just share with us what you meant by that and the significance of it.
Well, the actual term health information exchange is not defined in federal code anywhere for what we do every day and for the purposes that we do it. And what that has meant is we can't be utilized as a tool when any act of Congress is necessary to do COVID response or just to support any reimbursement models that CMS has or any CDC initiatives. Because we don't legally exist on paper and as defined in what we do and who is an HIE and who isn't, there's this it has created this lack of optimization, lack of utilization across the industry, where there are some superstars and some that are left behind because of that lack of designation and that lack of public health being able to engage and have something to go back to, if you will. And so the designation is incredibly important so that we can be utilized going forward to support this pandemic, the next pandemic, and everyday public health use cases, everyday Medicaid use cases, everyday emergency response, supply chain, procurement, like all of the things that impact our world and can be a part of a health data utility interoperability model using HIE. It's just really important that we are defined so that we can be optimized and utilized and be of service. HIEs are predominantly 501c not-for-profit organizations that are intentionally set out to do good and to be a neutral, vendor agnostic, results agnostic entity. And we would love to be optimized to the nth degree, and that's just not happening. And so it sort of feels like we're not a wasted opportunity just because we can't get a definition. And there's lots of reasons for that, and most of them are competitive. But in order to advance, and then using this COVID-19 moment as our moment to say, hey, let's do better now, it's an important piece of our future, I think.
Yeah.
And we are advocating for that.
Absolutely.
I would add to that, Mark, that, there are some good examples where designation has happened, in states. David has that in Maryland. We have a designation from the Department of Health Services in Arizona. And it does, to Angie's point, for all the reasons about being a nonprofit, a community organization, really working for the best interest of the stakeholders in the community we serve. It allows for efficient use of funds that are available to go further, faster, and be able to make more advancements than otherwise going through very robust procurement processes. In a lot of cases, procuring technology that is much more expensive than what an HIE can offer. And we've just have examples of where we've been able to partner successfully with our state agencies. So I feel lucky that we are in the state and across multiple states, that we have great relationships with our state agency partners, but that is not the case in all states. So I think the case Angie's making is, if we could have that across all states, look what would be possible. Making sure that there's the right foundation of requirements that an HIE would have to have, and the right technology in place, and all the things that are necessary to make that model successful.
Yeah, absolutely. Thank you both. I really appreciate it. So let's look toward the future. What is the future? I'll ask each of you, where are we headed overall in the next 2 to 3 years? What if we were to time transport ourselves 3 years from now, in this moment, what would we say had happened? So who would like to put on their gypsy turban and look in their crystal ball first?
I can start with what I hope we will see. I hope that through all of the efforts we've discussed here, as well as the broader efforts to advance interoperability, we will make some bigger strides in having a more robust interoperability system in our country. We talked about the good things we've been able to do in the pandemic, but you also mentioned the pandemic has identified the gaps that exist in our data infrastructure and the ability to securely and real-time exchange information. So I hope in the next 2 to 3 years, we'll be on the other side of the pandemic, and we will be identifying how we can really work actively within our communities and across the country to close those gaps, certainly leveraging all the things that we worked on today. I think with all the additional regulation that's in our space, it's reinforcing the identified need to focus in these areas. And so it's important that, we take all those directions seriously in the regulations and compliance so that we are moving in the right direction. But that's my hope, is that we will see really some quite significant progress in the advancement of interoperability across all states.
I certainly hope so too. Who's next?
Well, we have. Go ahead, Jonathan.
Yeah, well, I was going to say, I think we alluded to it at the beginning of the call, and this is a starting point, right? I think everyone says, oh, the interoperability and patient access final rule was published, we're done, right? Or TEFCA's here, we're done. It's definitely not the case, right? This is a huge monumental effort that's going to require iteration, and new use cases are going to come out. New means of connecting the data are going to come out. New thought leadership is going to come out about this, and so now we're at the starting point. We have a unique opportunity to really change the way data exchange is facilitated, and I think it's going to be, it's going to be iterative as opposed to revolutionary at this point, right? Like, no one said let's throw the rule book out that we used to do. We're going to still do the things that we used to do, but we're going to add to them. And so I think when we look, 3 years in advance, one of the big things in the core tenets of some of the interoperability rules is that data exchange is driven by consumers. And Mark, as you know, so you talked about that's never really happened. I mean, it's been data exchange on behalf of a patient, data exchange to support a patient's journey, but it's never been, I want my data to support my journey, right? And so I think that's going to be a fundamental mind shift that we're going to see in the industry. How quickly that's going to happen, I don't know. It is a big question mark. I mean, David talked about the amount of money you have to spend on the security and safeguarding PHI. That is a real concern for people as they facilitate their own data exchange across this ecosystem, right? Where it's being held today to where it needs to go, and via intermediaries such as HIEs or data aggregators such as us. Do you trust them? Do you want to use them? And so I think you're going to see that shift start to happen. That paradigm is gonna kind of flip, but it's not going to be, again, revolutionary. I think it's going to be additional on top of, because there still will be data exchange on behalf of a member or a patient or whatever. But it's going to be, you're going to start seeing more people take ownership of their data and use it for things that they think are valuable for their own healthcare journey.
Yeah, absolutely.
Yeah. Last time we talked, Mark, I think I said that was the biggest weakness in the industry, something that we have not effectively tackled. And I sure hope that we make progress over the next 3 years. I also hope that in 3 years, the information that we have going up to public health authorities is dramatically better than it is today, and certainly better than it was 2 years ago. We shouldn't have to look at studies in Great Britain and Israel to understand vaccine efficacy, to understand if certain risk factors are putting someone into the hospital. We shouldn't have to question whether there's inequitable distribution of therapies. Like, those things should be very easy to measure and to evaluate the outcomes and give to researchers. All of that, we collect all that data, Mark. It's all electronic. It exists today, and we just don't put it together. And so I believe in the next few years we will start to put that together. And I surely hope that we don't attempt to solve the problem with more burdensome reporting requirements. We don't need to do that. We have all of the information electronic today. Put it together, and we'll be able to answer big public health questions very rapidly.
Yeah, absolutely. Angie, I'm sure you have thoughts.
Well, I think where I think we will be in 3 years versus where I hope is maybe two different things. But so where I think we'll be in 3 years is there will be more affiliations of HIEs. So there will be more group, larger organizations that represent several jurisdictions, and so fewer independents. I also think that in 3 years, health equity and the principles thereof, and inclusive of that in our interoperability space, are actually going to drive us to be defined in states or in federal code, and that there will start to be some reimbursement models designed around that, and that will be incredibly helpful. And so I think that the health equity principles will also help support public health, utilizing HIEs as health data utilities, and start to put in some of that infrastructure. I think we've got a lot of policy work to get there, though, and so I think a lot of that policy work will be happening over the next 3 years. And so, sometimes that work is behind the scenes and under the cover, and you don't have much to actually show for it until it's in place and you've got a chance to build around it. And so I think in 3 years more, we'll start to be building around it. But we're still sort of on this next evolution of HIEs and getting there.
Yeah, I agree. Well, we have 6 minutes, which means, and I was going to close by asking for advice, which means each person can give 1 minute of advice. And I know that so it'll have to be your elevator speech advice. I'm sorry, it can't be longer. I'm going to go opposite way around my clock here. Jonathan, a piece of closing advice for our audience.
Just about interoperability in general.
Whatever you'd like to share.
I feel on the spot now. I'm wasting my minute. Let me think. So as we think about advice, I mean, I think I think there's a lot of information out there. I mean, David alluded to this. I mean, 77 pages of TEFCA. There's the patient access, and interoperability and patient access final rule, right? There's a lot of documents out there, US CDI documentation, Karen, Da Vinci, all these things out there. I would recommend just getting smart on, what HL7 is putting out there around FHIR, about how data exchange is going to go. I mean, ONC has put a stamp on FHIR as, the means by which data will be exchanged in the future. And I think that is something that everyone, who wants to talk about data exchange in healthcare over the next 10 years is going to need to know about, and how it's done, and, and the means by which this data exchange is initiated, whether it be, for continuity of care or at the behest of an individual. And so really understanding how this data flows, the standards that are being proposed, and how this data can be used for you and your organization.
Yeah.
Because whenever we're overwhelmed with this idea of compliance with mandates and regulations and things like that, it's hard to see the forest for the trees. This is actually a great thing, right? Facilitating better exchange of data in healthcare is amazing for so many people, as well as organizations and everyone who interacts with healthcare. Getting smart on it and understanding how you can use it for your organization, I think, would be my piece of advice.
Absolutely. Great advice. Thank you, Jonathan. And I agree, a lot of our audience are still not completely clear on what FHIR is and does. So that's a good place to start. Melissa.
My advice would be to keep a pulse on what is happening nationally and figure out how your interoperability efforts fit into the national landscape, but don't lose sight of the fact that healthcare occurs locally. And so you really need to listen to the needs of your community, your state, your stakeholders, because those change from state to state. And there's differences from state to state that we need to be aware of. So even as we're growing and we're serving multiple states and multiple communities, that local community input, that stakeholder engagement, and really making sure that the use cases that any of us are supporting meet the needs of our community is really what's most critical at the end of the day.
Terrific. Thank you so much. David.
Keep reading healthcare innovation. That's my best advice.
You get it. Thank you. The check is in the mail. Thank you, David. Angie, what would you like to share with us?
Seek out recommendations from your HIE community and your HIE leaders to help support a robust interoperability network that is inclusive of all health data, whether public health or Medicaid or claims, clinical, all aspects of health data, and know that they are there to support and trust and build out a data infrastructure that can be truly transformative and meaningful across the country, and also deliver locally.
I agree. So, well, and first of all, David, again, thank you so much for your kind, generous words. What I would say generally, obviously, I would love it for people to read our publication, but I agree with all of you. Our audience, I would urge you to really keep up on this topic. Things are moving pretty quickly. There are so many levels here. There's so many layers, as we've uncovered some of them in this discussion. And I think the leaders of provider organizations, CIOs, CTOs, et cetera, there's a whole new world that's opening up now. And there's so many possibilities to the future. I'm rather optimistic. I mean, yes, it'll be complex. Everything is complex. And in healthcare, we only go from complex to more complex. We never go to simple. But I think that what has happened this month in the policy world is great. And I also think that much more clarity will emerge in the coming months. And there will be a real opportunity for everyone, all stakeholders in healthcare, to participate in really meaningful exchange for the betterment of our patients and our communities. And I also just want to thank all of you for your tremendous leadership. You guys are amazing, and you're helping to lead the industry forward. So thank you very much. This has been a terrific discussion. Our publisher, Matt Rayner, has returned to conclude the session. But panelists, thank you so much. I really value each of you.
And I'll echo that. A big
Thanks
thank
for
you
having
to
us.
the panelists. A big thank you to you, Mark, for leading us through this opening session. A great way to kick off the Interoperability Virtual Day. And a big thank you again to our friends at LexisNexis Risk Solutions for their support with this opening panel. We now have an ever so short 60-minute break until our next session, which will be a discussion on interoperability and the Cures Act. Are you ready? So we look forward to seeing you all back here at 12 o'clock Eastern time. So until then, take care.
Thank you.
Thank you. Bye-bye.